Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Acadia Pharmaceuticals, Inc.
Good day. My name is Jesus Eric Piña Garza. I'm a professor of neurology and pediatrics at Centennial Children's Hospital. I'm honored to moderate a panel of distinguished nurse practitioners. Erin O'Connor Prange from Children's Hospital of Philadelphia and Tristan Dinkle from Children's Hospital of Colorado. Thank you for joining us to discuss the topic of the nurse practitioner as the medical home for the patient with Rett syndrome. This is possible due to a grant from Acadia Pharmaceuticals and the support from NAPNAP. The agenda for today will include a couple of case presentations about patients with Rett's. We'll talk about the pathophysiology and diagnosis of Rett, the treatment and symptom management of the condition, the incredibly large number of comorbidities and how to screen for these, and the communication with the patients and the caregivers. Without further saying, I introduce Tristan Dinkle to review the pathophysiology and diagnosis of Rett syndrome.
So, starting with when did Rett syndrome come about? First, it was noticed by Andreas Rett. First published a report in 1966 of some females that he had noticed that had an early onset of developmental delay, regression, loss of communication and of their fine motor skills, developing stereotypies within their hand movements, and irregular breathing. He saw that, he published it, and then Bent Hagberg also collecting some cases of similar patients, and he was able to publish his study in 1983, and he gave credit to Dr. Rett. So worldwide, the prevalence for this is 1 in 10,000 to 1 in 23,000 female births. Median age of diagnosis is about 3 years. As we go through what this disorder looks like, they are typically between the ages of 6 months and 3 years. They're starting to show these signs. And so we can have them diagnosed much younger, but also at an older age. More than 75% of these individuals may live to be up to an age of 45 years old. It is caused by a spontaneous pathogenic variant in the MECP2 gene on the X chromosome. MECP2, what we have found, is a very important protein. It's involved in the body. It's in very many aspects of gene regulation. Transcriptionally, it can repress, silence, and activate. The protein is involved in regulating gene expressions and is implicated in diverse cellular processes based on its reported interaction with over 40 binding partners. So it has a trickle down effect. So genetic testing is typically how we will find this disorder, because as we'll discuss in a moment, there's a lot of things it can look like clinically. But it is diagnosed with either serum or saliva based on testing and can confirm the clinical diagnosis and rule out the other genetic disorders. Um, it can provide information about a specific MECP2 variant. So often the families will want to know, where does it start? Where does it stop? What are the exact mutation areas? And it is needed for patients to be eligible for clinical trials and natural history studies. So, if you are struggling with what kind of tests to do, I definitely work with a genetic counselor to figure out exact testing for you and how that can help guide and support families long term. So, recognizing early signs and symptoms of Rett syndrome and when you should be ordering testing or pushing further for a diagnosis of any child. One would be developmental delays, any loss of purposeful hand skills. So saying they have something and then at some point they lose that skill. Stereotypies or stereotypic movements. These can include these hand wringings, tapping, anything that's movement disorder kind of in their hands. Gait abnormalities may develop a wide dyspraxia gait or tiptoe walking. It's going to be a very side to side kind of walk. Acquired microcephaly, social withdrawal, limited contact and social engagement, seizures, or breathing irregularities. And these are typically um, a breathing kind of irregularity. I'm not just thinking of the bigger stuff like sleep apnea or those kinds of things. This is a dysregulated breathing throughout their day. So to diagnose Rett syndrome, it is a clinical diagnosis based on consensus clinical criteria, which we will go through in a moment. The first criteria was published in 1984. It was updated in 2002 and then updated in 2010. The diagnosis includes typical or classic Rett and atypical or variant Rett presentations. It does require a period of regression followed by recovery or stabilization. And the presence of a MECP2 pathogenic variant is not required for typical or atypical, but it may be supportive following clinical diagnosis. And in 95 to 97% of people with a MECP2 variant, we will see meeting the criteria for typical Rett. So, what are the diagnostic criteria to diagnose both typical and atypical Rett? First, typical, they must have a period of regression. So they've had skills and then it regresses. They're losing skills actively. And then it is followed by a stabilization period in time. They must meet all the main criteria and all exclusion criteria. And we'll go through those in a moment. And then the supportive criteria is not required, but you'll often find that those are also found in their diagnosis. Atypical Rett syndrome will find a period of regression followed by stabilization. So both typical and atypical, you will see that. And then in terms of the main criteria, you should find 2 out of the 4, and out of the supportive criteria, 5 of the 11 to make a diagnosis of atypical Rett syndrome. So what do these criteria include? Main criteria is the partial or complete loss of purposeful hand use. If you have noticed, if parents say any type of loss, so they were, doing a certain kind of hand movement and now they've went back to a more broad and something they were doing before. That is what that can look like. Partial or complete loss of acquired speech. This can be they were using full words and they've gone back to baba gaga and these kind of adjustments to all the way to losing the speech. Gait abnormalities. They were walking pretty typically. Now they've gone back to something that might look a little more toddler-like, that's that unsteady. And then hand stereotypies. Again, these are those things that we kind of gave examples of, that tapping, the picking, the rubbing. So the exclusions, these mean that the patient cannot have these in place with the main criteria. The brain injury secondary to trauma is one that if they have that, that will exclude them from a Rett syndrome diagnosis. And then abnormal psychomotor development in the first 6 months of life. So again, they weren't developing regularly and then losing skills. They had an abnormal start to their development. And then the supportive criteria. These are things we are typically finding in these patients. Breathing disturbances. I already gave you an example of that. Bruxism, they're rubbing their teeth, they're grinding those teeth. Impaired sleep pattern, they're up and down all night. Peripheral vasomotor disturbances, they're going to have small hands and feet, but also cold is what we will find. They often develop scoliosis a little further on to their journey. Growth retardation. These patients are typically pretty petite in most ways. Inappropriate laughing or screaming spells. They have a diminished response to pain. And this is one of the bigger ones. They have intense eye communication. They are going to get you with their eyes. So some other diagnoses that can come about and be seen but been ruled out as Rett syndrome, which would be autism, cerebral palsy, Angelman, Fragile X, some mitochondrial disorders, epilepsy, Prader-Willi, Smith-Magenis, and many others. So again, genetic testing has come a long way, and we can really help differentiate these and have a clear path for the family to go down. This slide is listed for a big reason because before genetic testing got as developed as it was, there were a lot of disorders maybe lumped together because they looked a lot alike. But as you can note here, there are some very big differences that we've found as we've learned more about the natural history of these disorders and know that they're now very singular and different. So again, we've gone through the Rett ones. There's the regression, the loss of hand use, stereotypies, predominantly affects females, but still does affect males because it is on the X chromosome. As girls, we have two, and men will have one set. So we do still see it in both. The duplication syndrome, they're going to develop differently in that they have no regression. They have early hypotonia and global delay. They also have recurrent respiratory infections are so common, and it primarily affects males because it's an X-linked duplication. FOXG1 is going to look very different. Again, these were grouped together previously and kind of just seen as an atypical Rett, but we now know that that is not true. They have a congenital onset, no normal early development. They have severe developmental impairment and absence of speech and prominent hyperkinetic movements. We will see a change on their MRI, which we do not see typically with our Rett syndrome patients. CDKL5 deficiency disorder, these patients set themselves apart with an early onset epilepsy, often less than 3 months coming out from birth. They have severe neurodevelopmental impairment and limited developmental progress. So again, we're not seeing that develop, loss of skills. When should a patient be referred? If we're suspected of having it, as early as we can will help obtain a diagnosis, get therapies going, and most importantly, getting support for the family. So any patient with a developmental delay without etiology, no history of the brain abnormalities, communication issues, they're having seizures, they're having motor abnormalities, and referring them to, you can either go to a developmental pediatrician, a neurologist, or a geneticist, or if you're vast and knowledgeable on ordering your own genetic testing, you can certainly go down that path. Case study number 1 is a 15-month-old seen at the pediatrician's office. Developmentally was appropriate till 9-month-old, and this is the road that a lot of families walk, is the same kind of thing. And the parents notice a reduced mobility, lack of interest in playing with toys. When we dug into it with a little more with family, you'll see that they were crawling, but didn't stand or walk. Started losing some of the fine motor skills. Before was able to pick up a Cheerio and put it in their mouth, and now they kind of just knock them around, and they're not able to really get that into their mouth. Losing that pincer grasp. Language. They were able to say mama and dada, but no other words, had kind of lost that ability at a 15-month-old where they had a few more words. Low tone and microcephaly. Their head circumference has been decreasing as they've grown, and they notice that they are on the small side in their head. This, to me, is all a perfect reason to be placing a genetic order or referral to someone that can order those genetics and help determine, is this Rett syndrome or is this some other disorder? And it's a very important picture to put together and add all up for you.
Thank you, Tristan, for that very nice review of the pathophysiology and diagnosis of Rett. As stated, a complex, very complex condition that affects mostly girls because it's an X-linked related. Diagnosis is clinical, even though it's highly supported by the MECP2 mutation. And this is a good definition of a syndrome because a syndrome can be caused by many conditions. So the FOX and the CDKL5 sometimes present as an atypical syndrome because we have problems with synaptogenesis, which is a common ground, and that's the target of the newly developed treatments. So I'm going to talk with you about the treatment and symptom management of these patients. Until very recently, all we have is symptom management, which is the history of neurology. We didn't have a lot of cures. That's changing over time. But it's very important for many people with epilepsy, 60% of them, controlling the seizures is like controlling their illness. These patients are affected in many areas. Many of them present with epilepsy, many of them with movement disorders such as chorea or dystonia. A lot of them have autonomic dysfunction like Raynaud's phenomena or changes in their autonomic system. Many of them, as mentioned, have sleep apnea. A lot of them have hyperventilation or abnormal breathing patterns. GI is universally affected, whether you have constipation, which is the most common, or diarrhea or vomit. There's a lot of symptoms that are part of the condition. And then growth and nutrition is often affected because of the limitations. Scoliosis, also a common problem, bone health, and cardiac issues. So we have a lot of things that can be causing symptoms for this patient, and all of this is targets for our management, targets that can improve the quality of life. Now, patients with Rett syndrome often have a prolongation of the QT, and this is very important. So it's important to have awareness of that if it's present, and then awareness of using medications that may or may not affect the QT. Example, if you want to try an SSRI, because often these patients have problems with anxiety or frustration, you would opt for fluoxetine over citalopram or escitalopram that tend to prolong the QT. In some cases, you may need a medication for sleep, and it's okay even to use things like trazodone, but you have to be aware that that may increase further the QT. So you have to be concerned about what you prescribe. Now, you have to monitor their EKG and you have to have that periodically checked, perhaps on a yearly or every 2 year basis. There's a treatment that is more specific for some of the pathophysiology of the syndrome, is trying to restore some of the synapses that have been lost. Remember that these patients don't lose their neurons. They just get kind of disconnected. So when you talk with people with Rett and you evaluate, be aware that they're many times more aware and more frustrated than they can tell us about. So we have to treat their comorbidity just like anybody else that would have anxiety or depression or other symptoms. So we have now a medication that can be given as initially just oral suspension, and more recently, a powder form that can be mixed with water or juices and have the possibility of using it with lower volumes, expecting hopefully a better tolerability. If you go to the package insert, we'll give you the dose that was started on clinical trials. The clinical trials, like many clinical trials, is a forced dosing or forced titration in other cases. So you expect the maximum problems with side effects when you have only one option. In most cases, in centers of excellence, people have opted for trying a slower titration and a slower target based on common sense. So you're more likely to tolerate something that gets introduced slower than something that abruptly change your balance in the GI tract, for example. The use of the trofinetide is only for Rett syndrome. There's no other conditions that this applies to, whether it's the typical or the atypical Rett syndrome. We have on the clinical trials the Rett questionnaires, which are laborious. You have to look at a lot of things. But in my patients, sometimes that data is able to tell a parent that you are actually improving. So when you improve several points in those scales, it can tell you that you're moving the progress into the right direction. So I use them whenever I try these medications. Starting low and titrate slowly. Most of the centers of excellence have shared with me what I do, which is starting with about 25% the recommended dose, then move to 50, then 75%, and finally a full dose. Most medications, when we have a possibility of introducing the slow, we do it because it allows to provide a better chance of tolerating the treatment. And then we were able to see on clinical trials that the benefit for the majority of patients, or at least the average patient, was seen within 12 weeks. But that means that for some patients it took longer, and for other patients was a more significant improvement. So you have to give at least a 4 to 6 month trial to see if this is going to work for the patient. So it's good to have a baseline to say what is your routine for bowel movements. Many of them have constipation, so ideally, you could have a side effect of looser bowel movements that bring you into the balance, but you don't want to give it beyond that where it creates a problem. So many times you have to decrease the products that you are using for constipation to improve the possibility of tolerating. Sometimes you have to be prepared to increase fiber in their diet, kind of a bowel stabilizer to try to have a better consistency of the stools and less risk for diarrhea. And also be prepared to use medications like loperamide. Now, these patients, as you will hear throughout these presentations, require a comprehensive care, a multidisciplinary approach, more than probably any other condition I treat in neurology. So you have to be aware that sometimes you're using many medications, and you have to look at medications that don't only affect the physiology of the patient, like the QT syndrome, but also don't interact with the other medications in a negative way that increases the possible side effects. Now, there is new therapies that are being developed. This is just the beginning, trofinetide, but there are other medications that are trying to introduce the gene. So I will show you some of the trials that we have with TSHA 102. That's a trial that is both for adults and pediatric patients. And what you are trying to introduce is a MECP2 gene intrathecally to try to function as a satellite of the normal neurons to produce the things that are missing. We have the same kind of principle with the NGN 401, which is trying to introduce this intraventricularly. So it's more direct and try to again introduce a mini gene MECP2 to try to replace the defect. And there are some other medications like Bionetide, a product that is oral that gets through the blood-brain barrier and try to modify the imbalance that the MECP2 mutation causes on these patients. So, with that said, again, very complex condition, multiple members of the healthcare required. This is one of the reasons I feel nurse practitioners can house these and can bring the whole team in addition to the primary care physician in harmony to provide all the services. So Erin is gonna talk to you about the comorbidities and how to screen for this condition. Erin?
Thank you. Thanks for that great setup. So, we're going to talk about the comorbidities with Rett syndrome, and we're going to just start with a case. So, this is a 5-year-old girl with known Rett syndrome. So, she's already had the genetic workup, she has a diagnosis. She's recently moved to this area. She's coming to your primary care site for the very first time. And we want to think about what questions should you be asking? What should you be exploring at that first visit as you meet this child and her family? And so, as Dr. Pina Garza just spoke about, we know that GI issues are one of the most prevalent things that we see as part of this disorder. So asking if there's any specific feeding plans for this child? Is she orally fed, G-tube fed, or both? Do they have active reflux or constipation issues? And if so, are they being managed with medications or just food or other things that the family is doing? And are the symptoms well controlled or not? Checking in on sleep. So we know that sleep is a huge issue. And when the child is not sleeping, that means the parents aren't sleeping. And many of our parents are taking care of other children. They're trying to work, they have other responsibilities. And so if our patient with Rett syndrome is not sleeping, that means that whole household may not be functioning optimally. So making sure that we're addressing this and bringing it up. Looking at behavior, do they have any anxiety, depression, aggression? What is the family kind of dealing with at baseline, and how can you help make sure that that's being managed or addressed appropriately? Screening for epilepsy. Do they have seizures? Are they on medication? If they are, then maybe helping get them into a neurologist in the area as they're moving and relocating and trying to start their new care team here in this area. And then what's their mobility in the community? Is this a child that is walking and ambulatory, or are they in a wheelchair? Do they need things like handicap placards? Do they need equipment? Do they need gait trainers? Do they need things that they may need a rehab clinic or a seating clinic to make sure that they're getting that equipment? Have they had their EKG to look for prolonged QT? So if it's been several years or they've never had one, primary care can order that at that first visit. And then just making sure that they're kind of plugged into the Rett family resources just to have some support to hopefully meet somebody in the area that can help support them in this journey as they're moving. So we're going to go through, now that we know kind of what questions that we want you to think about and to ask at that first visit, we will just go through kind of why those questions are most important. So Tristan gave you a little bit about kind of the pathophysiology of Rett syndrome, but we know that it's a neurodevelopmental disorder, and it is primarily brain-based, but it really does affect multiple organs. And as she said, it's really because of that downstream effect, lots of proteins are being affected, and so many organs in the body are affected. The Rett consensus guidelines were first published in 2020, but they really emphasize the coordination that needs to happen between the primary care team, which is really the home for the patient, with all of these subspecialists that they may be seeing. So our Rett patients still get ear infections and strep throats and all those things, and primary care is really the center for that, but they also may have many other specialists involved in their care. So when we look at this slide, it shows you that any given child may have 6 or more subspecialists that are involved in their care. So neurology, developmental pediatricians, GI doctors, speech therapists, physical therapists, occupational therapists, orthopedic doctors, rehab doctors, nutritionists. So they may have many providers, and being that kind of care home for the family, if you can kind of just help them get their team together and make sure that each team knows what the other one is doing, right? So many times these families are seeing GI at one hospital, they're seeing neurology at another hospital, they're seeing therapists at the school, and the family's kind of lost in a way of how do we coordinate this care? At Rett Centers of Excellence, we try to do that, but at many other sites, there may just not be the personnel to do that. And so the primary care home, the nurse practitioners and the pediatricians in their primary office are really often the ones who are kind of led to help the families hold this together. So looking at kind of this different systems that can be affected. So we know this is primarily a brain-based disease. And so we have lots of neurologic issues that we can see with these patients. Epilepsy in up to 90% of patients, breathing abnormalities, hyperventilation, breath holding, air swallowing, up to 95% of patients, sleep dysfunction in 80 to 90% of patients, movement disorders, 60 to 80% of patients, and behavioral issues, anxiety, depression, autism-like picture, up to 97% in some of these studies. So huge numbers. This is not just something that's affecting a couple of the girls. The majority of our patients have multiple different symptoms that they're presenting with and needing management for. Outside of the brain, you heard a little bit earlier with Dr. Pina Garza talking about prolonged QT. So about 10 to 18% of the girls will have prolonged QT. It's not a huge number, but it's enough that we need to know about it, especially with the medications that we're using. So making sure that they're having that screening at baseline and then at regular intervals. Constipation and up to 80%. I think many of us who do this on a day-to-day basis would tell you it seems like it's 100% that have some type of constipation reflux, about 40% with reflux. and another 40% that are showing some type of growth abnormality, so either underweight or failure to thrive. Endocrine issues, we can see puberty issues in about 19 to 28% of patients, um, specifically looking at precocious puberty, low bone density in almost 60% of patients. When we look under orthopedics, scoliosis, about 80% of patients will have scoliosis that'll be identified throughout their lifespan. Hip displacement in about 50% of our patients. We see this in greater numbers, especially as they get older and we have increased tone and contractures developing that many times the hip displacement can happen. And then fractures in about 28 to 32% of patients. So what should we do kind of annually screening? Bone health, it's something really easy when they're getting regular blood work done at the pediatrician. We ask for a vitamin D level once a year just to screen for that. And if there's concern for fractures or other concerns that they may have osteoporosis or low bone density, then we'll order bone density screening as well. Scoliosis assessments, as in many of your other well visits, just screening and looking at their back at every visit. When we're seeing in neurology, we're looking at their back at every visit as well. If there is any type of curvature that is assessed in the clinic, we recommend a baseline x-ray. And if there's any signs of scoliosis, we do an early referral over to orthopedics to watch them yearly and to screen. Cardiac screening, we do that EKG at diagnosis and then recommend every year to every few years, and then making sure we're checking it again when they hit puberty. Ongoing at every visit when you're seeing them for their well visits, just looking at growth and nutrition. So as Tristan said, these kids tend to be pretty petite. They tend to be low for both height and weight, small hands, small feet, but they should be maintaining their own curve. So even if they're below the curve, we want them to maintain their own curve. If we see them dropping percentiles, that should be something to kind of raise a red flag, get them referred over to nutrition and GI early. Again, monitoring for the reflux and constipation and seizure frequency at every visit when you're seeing them. And if it's not well managed, making sure you're sending them back to their specialist to kind of update that care plan. So looking at these a little bit more in depth, when it comes to neurology, what are the things that we, and I say we because I'm coming from a neurology perspective, but looking at seizures versus Rett spells. So seizures are abnormal electrical activity in the brain that's causing an epileptic seizure or a seizure coming from the brain. A Rett spell, it looks the same each time, but it's not coming from the brain. It's not coming from this abnormal electricity in the brain. It's not an epileptic seizure. It's very difficult to hear about a spell and say, is this epileptic or not? Many of the girls will have these Rett spells. We ask that we get a clinical history, we take videos if possible, and we want to do the best that we can to manage these spells if they are interfering with the child's life. Gold standard is to do long-term monitoring EEG to try to capture these spells and say, is it epileptic or not? If they are having epileptic seizures, then they need to be on medication to try and manage them. The seizure medicines we use are extensive, which is why I don't list them all here. But all of the medications that we would use in our general neurology patients, we're also using with our patients with Rett syndrome. If they are intractable medication, if they're having prolonged seizures, frequent seizures, needing rescue, where they're not well controlled, things like ketogenic diet and VNS can also be considered. And then we talk about rescue meds as those meds that you can give if a patient is having a prolonged seizure that may not stop on its own or clusters of seizures that are impacting their day. Movement disorders, dystonia and tremor are the most common things that we see in our Rett syndrome population. Dystonia, we often will see in the girls, specifically early in the morning, if they're awoken and they don't wake up on their own, but a family goes in to wake them up for school, or if they have a quick movement, that can provoke a dystonic event. But we can see them at other times as well. And essentially, the muscle kind of goes into a contracture. They're stuck in that position. It can be painful if it's prolonged. And if it's happening frequently, we look at meds that can decrease the frequency of those episodes. So medicines like oxcarbazepine and clobazam, which are also seizure medicines, those can be used for dystonic events. If the episodes are prolonged and the child is in pain, if they're lasting 15, 20 minutes at a time, we may use shorter acting benzos like clonazepam to help break the episode and to help prevent the pain that the child is going through. Medical marijuana is also used for both seizures and movement disorders. And in some of our patients, especially post-puberty, we've seen tremor really increase after they've gone through puberty, especially when anxiety is increased. And some of these patients being away from their caregivers or feeling more unstable when they're standing or they're ambulating can increase anxiety and can increase their tremor. Autonomic dysfunction, we heard a little bit earlier about the cold hands and feet that happen. Oftentimes they can also be discolored and be blue or purplish in color. Breath holding, hyperventilation, all of these things are really common in our kids. Many times the breath holding and hyperventilation are short and they don't impact with their daily life. But other times the hyperventilation can be so frequent that they become cyanotic, the family is seeing color change, and it can be really distressing to both the child and the caregivers. We have seen some improvement with hyperventilation in using trofinetide, which was mentioned earlier. Sometimes we also use topiramate to try to help with that. The other thing I would mention is that when you're hyperventilating, you often become a little acidotic. And so if you have routine blood work that you're ordering on your patient, you may see that CO2 level is very low. That's pretty common in our girls that hyperventilate. It's more so if they're hyperventilating and they're also on medications like topiramate that can cause an acidosis. And if this is causing symptoms, you may see things like sodium citrate used to help supplement and to help those the CO2 level come back up. Sleep difficulties, in that earlier slide, we saw up to 80% of patients can have sleep difficulties, both trouble falling asleep as well as staying asleep. Starting with things like melatonin, which are available over the counter, are considered fairly safe. Low side effect profile, they're available in liquid and easy to give. Typically, that's where we start. If that's not helpful, other medications like clonidine and trazodone, gabapentin can be used. We spoke a little bit earlier about trazodone and prolonged QT, so just being aware of that, but it is a medication that can help with behavior as well as with sleep. Gabapentin, primarily a seizure medication. It's also used for restless leg syndrome, but can be used in this population to help with sleep. Behavior, lots of these kids will have anxiety, depression, but also give that autism-like picture. So as Trista mentioned in her slides, I think she said that the age of diagnosis is around age 3, which is great, where that number is getting younger and younger as exome testing is becoming more readily available and covered by insurance. But it used to be that many of these girls were older by the time we got a diagnosis. And so they first would get a diagnosis of autism before they learned of their genetic changes and the Rett syndrome diagnosis. And so, autism that in and of itself, we know would not be secondary to something else. So if you have Rett syndrome, that really is an exclusion in the DSM-5 criteria because we know that the primary issue is Rett syndrome. That being said, we tell families that if they also have an autism diagnosis, it can help with services like getting ABA therapy in school, which can really be helpful in helping the child learn how to manage their behavior in the classroom, as well as getting like BCCs and therapists in the home to help the family with behavior. So many times you'll see both of these diagnoses on their chart. And medications like fluoxetine and sertraline can be used to help kind of with mood and behavior. And if they are aggressive, you'll often see antipsychotics also being added, especially kind of those post-puberty years. In terms of GI and nutrition, reflux, delayed gastric emptying, constipation are kind of the biggest issues that we see. We're really lucky to have a GI doctor who works with us in our Rett clinic. But, if you're seeing this patient in primary care and they're struggling with these issues, just getting an early referral into GI to kind of help establish care. Reflex medications are also needed in these patients. Constipation meds. Again, as you heard earlier, if they're starting on trofinetide, those medications may need to be decreased or stopped. But again, working with a specialist trying to help you as they're escalating therapy on things like trofinetide. Simethicone drops are really helpful for abdominal distension. Many of these girls will air swallow. If they're G-tube, you can vent them pretty easily, but if not, their bellies can really get full and distended and they can be uncomfortable. And if they're full of gas or if their reflux is terrible, that's going to make them not eat well. And if they don't eat well, we're going to see changes with weight and failure to thrive. So all of these things are intertwined. So just trying to do the best we can to manage the symptoms to optimize their care. In terms of growth and nutrition, one of the big things is to ask if they are oral feeders, is they're coughing, choking, gagging when they're eating or drinking. If a family is saying they choke or they cough many times when they're drinking liquids, that child should have a swallow study if they haven't had one within the last year. We want to make sure that they're not aspirating and that they are safe to orally feed. And many of our patients, they may not be able to drink liquids, but they're able to eat oral solid foods or purees. And so we talk to families early about G tubes, and that a G tube does not mean that their child's not going to be able to eat or partake in family meals. It could be just a supplement. So some of our girls are able to eat purees or a really fine chop orally, and then they have their G tube for liquids or for supplemental feeds if they're not able to consume enough calories. Because chewing, swallowing, and coordination of that can be difficult for these kids, we often see that meals can take 30 minutes or more. And so they often will fatigue before they're able to consume enough calories to maintain their weight. For orthopedics, scoliosis and kyphosis are issues. So again, screening them at every well visit, x-ray if you're seeing any signs of scoliosis, and then if there is a scoliosis, referring to orthopedics. We typically will see bracing if they hit a curve of about 25 degrees, at least in our institution, they start bracing around 25 degrees. And if their curve is past 50 degrees and is starting to impair their walking, if they are ambulatory or impacting their respiration, then we may see surgery. And so some of our patients are not ambulatory, and parents will say, well, why do we need to fix the scoliosis if they're not walking anyway? But if they have a 65, 70-degree curve, their lungs may not be able to expand well, and risk for pneumonia goes up. And those are the comorbidities that can cause early mortality, which is what we're trying to avoid. So many times the orthopedics will recommend surgery. Tone management. Many of these girls have low central tone, but as they get older, especially post-puberty, we can start seeing some increased tone distally, as well as some contractures, especially if they're up like this with their hand wringing all the time. You can see contractures at the elbows, or we can see contractures in the lower extremities if they're not ambulatory. When they're young and they're in elementary school, they're often getting lots of physical therapy, but as they phase out of that, they may not get as much physical therapy. They're bigger, so that their parents are getting older. They may not be able to get them up and move them as much. They start to see contractures in the lower extremities as well. And then endocrine, we touched a little bit on that early, but precocious puberty. So we've had girls as young as 5 present with breast buds and pubic hair. Some of them will start to see these early changes in puberty, but then they'll stabilize and they'll still go through puberty at a typical age. Other times they need to be on medications to suppress it. But if you're seeing signs of precocious puberty, send them over to endocrine, have them kind of evaluate for labs and to monitor them. And again, if we're seeing vitamin D issues, supplementing the vitamin D, but if we're seeing fractures, we'll also refer for bone density testing. Many of these kids, as we talked about, are on seizure medications, and we know that you don't absorb vitamin D as well when you're on seizure medication. So it's just putting another risk for them to develop osteoporosis and issues with bone density. We talked about meds already with the prolonged QT. Again, just being aware of those. It's not a true contraindication, but it just means we need to be aware of it. And if you're using those medications, that we should be looking at EKGs a little bit closer, and to have our cardiology colleagues on board as well. Genetics. We are, again, lucky to have a genetic counselor with us in clinic. But if this is a new diagnosis, or this was a 5-year-old family that moved to your area, if they're thinking about having other children, referring them to genetics to talk about future family planning is really important, as well as just learning about their specific mutation. So depending on what type of mutation it is, what amino acids are affected, we're often able to at least give families a little bit of prognosis about, is this more a mild severity, or more moderate or severe severity in terms of the clinical phenotype that we're expecting to see with their known mutation. And emergency care planning, just making sure that our families are prepared to be out in the community, to be in school, to travel, to do all the things that our other kids are doing. So making sure the family has a seizure action plan, knowing which rescue medications they're using, whether it be intranasal midazolam or rectal diazepam or buccal clonazepam. Lots of medications can be used. We want to know what specifically that child needs and at what time frame it should be given. So is it for prolonged seizure more than 5 minutes, a cluster of more than 3 seizures in an hour? That should be determined by the neurologist, and there should be a seizure action plan that they have. If they're traveling and they're not going to be in their local hospital, we recommend that they have one of these plans with them to present if they go to an outside ER. Um, Again, making sure that they know the difference between a seizure and a Rett spell, so that school nurses or other providers in the patient's care are not over treating with rescue medication. And making sure that they have all their meds when they travel. So things like trofinetide that previously were just oral solution, they were large volumes. We needed to make sure that families had letters to take that on the plane with them. That it needed to be refrigerated or in the cooler with an ice pack. So making sure that the families had those letters that they needed to travel. Now, trofinetide is available in sticks, which makes it a little bit easier to travel for these families. And now I'll turn it back to Tristan so we can go over communication with patients and their caregivers.
One important thing with having patients that are nonverbal is really understanding that they do have a cognitive potential that we are not able to assess to their full capacity. So, severe motor and communication limitations really do mask what they're able to do cognitively. Many individuals do show that they have receptive language. They understand what you're asking, they're just not able to tell you back verbally with what they need or what their opinion is. So, what we are using is often eye gaze and nonverbal responses to indicate their understanding. The assessment challenges with this is that standard cognitive tests are not really able to be processed with these patients to then written down and understand what is their IQ, what is their ability. And we really do require alternative evaluation strategies. And this can be worked out with either neuropsych providers and kind of things to really understand what is their cognitive ability. But one of the most important things we do use is augmentative and alternative communication. So using an AAC tool, this can be an eye gaze device, communication boards, speech generating devices. Another issue is that typically, communication devices that you see when people are nonverbal are needing to, you can push buttons, you can use your hands. And with this type of disorder where they don't have good use of their hands, besides maybe being able to hit something, is that you have to use different ways. And so one is the eye gaze technology where you can ask them a question and they can use their eyes. It is a setup just for them, their height, their build, and how they use their eyes to be able to point their eyes and select things on a screen. So you're able to engage, you're able to give them autonomy and a higher quality of life with being able to say things. Um, Implementation requires training, consistent use, and so it really needs to be tailored to not only their environments and where they're going, but also to the child's abilities. Some people using these devices can have lots of things on the screen and be able to navigate through those. Some of them need it a little more simple so that they can get to what they want to communicate. We have one patient, she is in her 20s, and she has some inappropriate jokes loaded onto hers because she is in her 20s and she can make a joke about something or she can make a joke about a cute boy. And so these things can not only be what color do you want to wear, or are you hot, are you cold, but it can also be, the things that are important for quality of life, such as jokes and things that make you smile. So these can really be expanded beyond just the simple things in life. So role of, having a physical therapist, occupational therapist, speech and language pathologist in their team is really important because again, the physical therapist can work on the mobility and posturing, helping with communication. If their body is all slumped over and we're using a device that is used for their eye, they can't communicate. So we need to have all these pieces in place. Occupational therapy can help determine can they use their hands to some degree to use an equipment of some kind or coming up with adaptive equipment for that. And then the SLP is working on communication strategies, how to use that AAC. Do they do better with this kind of device or this kind of device? It's really teamwork with having all these people on board, and by your primary care provider is the one writing for these types of things to bring these people onto board. So it's collaborative to help maximize their independence and purposeful interactions. Integrated therapies happening again at school, happening at if they're at a day program or at home, really helps improve both their motor and communication outcomes with having everyone involved together. All these things we've discussed today, we really do try to encourage to focus on all these things, but we still do miss some things when treating Rett syndrome. There are things that still just really make lives hard for caregivers and for their loved ones with Rett syndrome. And so the top 5 concerns from caregivers, um, based off our natural history study that we've been doing, is communication. Communication, communication. Again, these parents are having to read what is their kid feeling based off eye movement, um, facial movements, whether they, can do different things. And so it's really tough for these parents to continually play a game of charades with their child to communicate. And it really comes into place eh, when, there's pain, when they're having a tough emotional state, things like that, that are a little harder to piece out from just the everyday, do you want this or do you want this kind of answers. The next is seizures. So getting a good team on place to help treat their epilepsy. Hand use, again, not being able to grab things to facilitate eating, holding things. Uh, it's all the little stuff that really can balance um, their walking and their movement. Again, they can get up and walk. There are some that are wheelchair bound, but still the balance and strength of their body is very difficult. And then constipation can be a really hard thing to treat, partly because it can often swing from the two variabilities of constipation and then too much medication is them having diarrhea. So, what does that role of a pediatric primary care in the care of patients with Rett syndrome look like? So, they should be seen regularly for their wellness checkups. The regular routine stuff as they're little, but as they get older, continuing to bring them in yearly or bi-yearly to continue to screen, keep them up to date on their immunizations, and continuing to, as with all your patients, but these ones in particular, really knowing that the flu vaccine is important to help prevent respiratory um, disease through the winter. Parents and caregivers should keep a binder of their health records. So, if you can, giving them when you do test, you would do an EKG, you do an x rays, giving them reports of this. It makes it helpful when they're having to go to all these specialties that Aaron previously discussed. If they have a copy of these things, because systems don't always talk like we hope and want them to, it's great for these families to have it on hand and say, "Oh, you want a copy of this? Here it is. I have it." Especially when you do the genetic testing, I think these families, those tests go out into nowhereville sometimes, and these families really do need them moving forward to go into therapies and get treatment and things. Uh, and so educating them and really helping these families understand um, how they can support their kid as they go through school. So making sure there's a present of an educational plan, whether it's an IEP or a 504, having documentation of their therapies, how often they get them, what is the focus of those. And the educational plan, rettsyndrome.org is mentioned here as a great resource that has some um, different examples of ways to support these families. Assessing for family stress, whether it's financial, social, fatigue. Aaron was mentioning if they're not sleeping, and nobody in that house sleeping. And so, really, how can we help them get back into routine? Talking with the sibling, like it can be a really long road for them. And so, what does that look like in supporting them? The parents' physical, mental health, sleep, grief, anxiety, depression, all of these things can happen with dealing with a loved one with chronic health needs and really make it difficult because they are the ones that uh, are doing the support. And if we are not checking in on them as often as we should, it can make it difficult. And I know that when I ask these parents, are you taking care of you? I would say about 60% of them all start crying immediately, knowing that they aren't and that it's a lot. And even just having someone ask about it, you can't fix it, but we can provide support. This is a hard, long road, and the more people that walk alongside them makes it a lot easier. And then quality of life and marital impact. Uh, there is a very high rate of people with disabilities that their parents divorce. And so the more we can support these families, um, both together and apart, um, helps the child long term. And then knowing what resources to reach out for. There is available in the community, both insurance resources, filling out paperwork, getting them disability permits, getting them waivers, the support for getting them all lined up with this. And with adolescents, as they start to move into adulthood, getting guardianship stuff in place. Clinicians might need to write letters. We do this a lot every week at our different centers of excellence is writing letters of medical necessity for equipment and support and again waivers and the things that they might need. So just taking those extra steps with these families can lead to really big changes. Those parents are going to be your guide, your teammate, your expert. They know their child best, but they also know Rett really well, usually once they've been diagnosed. And so just allowing them to also help guide um, that really giving the best parent support we can leads to the best outcome for the children. The more we look into this, the kids that do the best, as they become adults, do the best are the ones whose parents are going the extra step for their child because they're being supported, they've been taught, and those sort of things. So the more we can do, the better the outcome for an individual with Rett. And then asking how the child communicates best. When we go back to communication not only being the most important thing, is that we utilize as that providers, is that we say, hey, how do they communicate? Is it I hold something up or do I ask a question? Do I wait for them? Do they blink at me when they're saying yes? Do they turn away when they're saying no? These little things so that when you come into the room, you can talk with the child and really wait for them to reply and communicate with you will go miles above with these families of just pausing to care with them. Listen when they speak. When these parents are saying, nope, my kid is in pain, something is wrong, not saying, well, it's this, or they've hit a change, a developmental change that is not typical for them, really listening because often what we'll find is that these parents are saying, well, we said this, and they said, oh, that's just Rett. And that's very rarely the situation. That it can be a UTI, it can be a gallstones, it can be constipation, or they've broken a foot. Um, and if you hit a wall and you're like, okay, we've tried all these things, I encourage you to reach out to one of the Rett Syndrome Centers of Excellence because on rettsyndrome.org, if you go there, you can reach out and help these families through your centers and saying, I've tried all these things. This patient's still doing this. As a primary care, we want you to be the center of care. We want you to be the person in the middle that's getting all of these reports from everyone. And we're happy to help support you along that road and really get these families plugged in the best we can. And I think that is it. I'll hand it back to you, Dr. Pina Garza.
Thank you. Thank you for great presentations from Erin and Tristan both. One of the things about Rett syndrome is like we have to be aware, as was mentioned earlier. We keep saying kids, but this is a condition that is more prevalent in adults. It's always start with symptoms in children, but children grow and become adults. So we have to be always aware. With kids, always the parent is the best advocate. We try to get their second or third in place, but they need a lot of advocacy. And same thing, we talk about girls because it's predominantly girls, but we have males with Rett syndrome. Remember that especially the atypical, where it's not an X-linked condition like CDKL5 or FOBS, we have about 3 to 5% of kids, male, that have Rett syndrome, mostly atypical. There's not a better example of a need for multidisciplinary approach. These people really need us to help them. I want to emphasize that those brains are still there. They are unfairly disconnected by lack of synapses, but these adults or kids, girls mostly or boys, they are often frustrated, often anxious, often down, and they need medications like anybody else. We have now diverse approach to try to manage every symptom, but then we have medications that we can use to improve, which to me was a new thing when trofinetide became available. Before that, all I saw was decline, decline, decline. And even though we said there's a stabilization, the decline continued due to the disuse of the body. So I never had a patient before that was stable. They were all losing ground little by little. So now I have had a few patients actually. I see them on the next visit and they're doing better. That's very encouraging. It's for me, imagine for the parents. So the diagnosis is clinical. The MECP2 is now going to be hitting us on the face more often because it's part of the diagnosis of developmental problems and epilepsy. So 97% of the time when we see it is going to be followed by clinical symptoms if we don't order specifically for that, but not always become symptomatic. And then we have a medication that is the first approved by the FDA, trofinetide, that many times can help the patients to decrease the burden of symptoms and disability. So I hope all the information shared with you help the patient primarily, but also the families that are dealing with this condition. And I would pass the microphone first to Tristan for some closing remarks and then to Erin.
Well, thank you. I think to me that one of the most important things is just um, really supporting these families with everything you got. You might not always have the perfect answer for them, but getting them plugged in with other families is important, whether that's through one of the Rett foundations that are out there or getting them plugged in even to social media, where there's groups by state. Every state has their own Rett group that supports each other and helps each other walk through this. Or even on social media, there's disability groups that help them navigate this road with others that are in the same situation in the same state with the same Medicaid and hoops they have to jump through. So any support you can give families that way is, even if you don't have the perfect answer, I think will help guide families and goes miles for them in terms of making their quality of life better.
I echo all those thoughts. I would say it's definitely an encouraging time for Rett syndrome. When we're seeing gene therapy is coming into clinical trials, we're all excited about what the future holds, and trying to support these families the best that we can. And I would say, just as Tristan said, it's important to empower the parents. It's really, if we could empower you as primary care providers, we may be Rett experts, but you guys are seeing these patients on a more regular basis, often much more frequently, and have really good relationships with these families. So just know kind of your importance in their care, and reaching out to those subspecialties. If you see something that doesn't seem right, reach out. I think most of us would be happy to hear from you, and have a quick discussion via email or phone. If something just doesn't feel right or you have concerns, bring them up.
Thank you very much for joining us today. And we hope that the information shared with you will help the patients and the families that suffer with this condition. So, again, this concludes our program, and thank you for your attention.